So, questions, comments? Oh.
Thank you very much. Thank you to distinguished colleagues. I benefited very much. One interesting thing is that when we speak about demand and supply of a service, and when it comes to health services, I think directly demanders are, no, direct demanders are the patients, but indirectly demanders are all the drug factories, all the factories producing all those commodities. So now, if we take this, or I mean, sorry, but if you take this into account, how do you plan? I mean, any colleague can answer that issue. How do you plan to make a distinction between this, I mean, extra or supplementary insurance and making a proper public-private mix? Because I think all these companies would prefer to have the system towards the private area and to have the system to have a complementary insurance system, because I think the payment, much as all over, the payment would be, in general, higher in the second case. Have you made, I mean, your researchers, sir, and your researchers, have you come to any kind of conclusion in this respect? Thank you very much.
More questions?
Are there any more questions? Okay.
Kayhan Pala from Bursa, Turkey. Thank you very much for your presentation, both of you. I have two questions, both of you. Firstly, is there any differences between groups like religions, ethnic, etc., because of this system, public-private mix? And the second one is, what is the position of Israel Medical Association and health workers union, especially related with dual practice of physician? As you know, thank you very much.
All right, thank you very much. And I think my question could be relevant to perhaps all the panels from here forward when we talk about particular areas. And what I'm wondering, and especially it occurred to me following one of Danny's slide about different forms of privatization, so different countries experimenting with different forms of public-private involvement, and it's something that's troubling me for a while. We do have a psychologist in the room? No psychologist? No one does? I don't need a psychologist at the moment, but maybe later. No, it's because I'm thinking about the political culture. So to what extent is it the case, political culture, professional ethos, and the rest, to what extent is it the case that if you create particular economic incentives, say to doctors, to social workers, the next panel, etc., is it always the case that those professionals will go with the economic incentives and not, for example, with their professional ethos? And say, to what extent will they order more tests just because they can? To what extent will they prefer to work in easier jobs and instead of working with more difficult, more challenging, but more important patients? To what extent will managers make those decisions, cost-cutting decisions? And I live at the moment in Britain, and there is obviously, following Thatcher, etc., there is all kinds of forms of privatization, and yet you see, in some areas, you see different reactions. You see, it's not the same extent as it is here. People react differently to forms of privatization, which made me think about this issue, that to an extent you think, okay, you put people before incentives, obviously they'll go where more money is, but it's not always the case, and I wonder how deterministic this is.
Well, thank you both for very, very stimulating presentations. I want to point out the process, which I think is important for the comparison with other countries, with regard to the overall health system in Israel. David pointed out correctly that in 1994, law finally reorganized a system which we inherited from the pre-state era. And as David says, it nationalized a few things. First of all, the insurance. Before, about 80% or 85% were insuring the sick funds, which existed before. They were not created by the law. And the insurance became national, 100% nationalized. It nationalized the health tax. Before, people paid to the health sick funds, and now you pay a tax, which is also in it. Then it standardized a health basket, which is, this is what, you know, healthy Israeli citizens should have. So it created a standard, which I think was very important. So those three things, in fact, were nationalization. But look what happened since then. In the last 20 years, has been a steady attempt to undermine those principles, David. Namely, the fact that out-of-pocket participation increased, you have to include the supplementary, you have to include the private insurance, and then you'll see that, in fact, the basic idea of this very good law is now being as being changed, and in many respects, it goes against the main thing, and leave aside the mental, dental thing, and so on. And we also know that the government expenditures in general went down compared to what it used to be. So even though we still have a nationalized system because the sick funds are not private, there's been an erosion, a steady erosion by governments to undermine the basic idea of this law, which finally, I think, had in mind the law, that health insurance should be equally distributed. This is what has been undermined in the last 20 years, in my opinion, and in Danny's opinion.
Okay, I'll just start with the informative question.
I will try to address first about the IMA, the Israeli Medical Association. The Israeli Medical Association, on one side, supports increasing the public healthcare budget and has strongly advocated for, but in parallel, they support the idea of expanding private work within public hospitals, and even they were one of the groups that opposed. There was a committee created by the former Minister of Health, Yael German, who decided to put a very small cap to private private health expenditure in private hospitals, and they strongly opposed that cap. So they have a kind of contradictory stand about that. Concerning, I completely agree. In fact, when several years ago there was an attempt to include oncologic drugs within the supplementary insurance, one of the agents that strongly worked for that were the drug companies. In that sense, at least as I understand, the original NIH law was thought in order that the public sick funds would be a kind of a kind of check and balances, because they should be the proxy of every individual patient in order to stand for the interests of the patients, of the members of the sick fund, and not for other interests. In my view, one of the problematic results of the selling private insurance or being the owners of private hospitals is that that original task has been undermined. Concerning Amir's question, I would think that there is a culture. I don't think that all of us are only rational profit maximizers. But one thing that happened in Israel has been the Americanization of the professional culture of the medical profession. If it was in the 30s, 40s, 50s, and 60s more influenced by a more feudal but less capitalist European medical culture, since the 70s and the 80s, it has been Americanized. And part of the Americanization is that idea that you should be able to earn like a physician makes in the US. And that is very problematic. So I think there are culture. I don't think that all of us are only profit maximizers. I do think that the kind of architecture of incentives influences, especially when it is combined with cultural changes. And concerning Itsik's comment, I have nothing more than agree to it.
So I'll start with the last point. I almost totally disagree. Sorry. I almost totally disagree that there's been a serious undermining. It just depends how you look at the numbers. There's no proof that health access inequities have been increased by these changes. There is certainly no proof that health status has been affected, because we know that these things are marginal to health status. What's really the most important thing is education. And I think the focus on this, I'll just call it the alpha 10% that we're talking about here, is way, way out of proportion. In absolute terms, the government has increased its funding. So you could say, well, what good is that if it's not in relative terms, if it's not per capita? Because it's not clear that you have to increase per capita, and that if you don't, you're undermining the system. There are questions of efficiency, there are questions of incentives, and of course, I would love it if the health system had more money. But it's a mixed picture, and that's what we're talking about. Is the mix good or bad? The supplemental insurance expanding is not the only privatization, because it was heavily regulated. The supplemental insurance was also nationalized in 1998, and it expanded access to health service for a great part of the population. So it's really, half full, half empty cup. But the reason that I object a bit to the half empty in the case of health is because health, compared to all the other sectors, has suffered the least reduction of general government revenue input. And I think that focus detracts from the more central issues of the long-term, the mental and the dental, and that was also part of the National Health Insurance Law, that all those things were supposed to be nationalized, and they weren't. So,
supplementary?
What?
Question? Could I have a supplementary?
Well, let me finish, because we're running out of time, and
I'm asking the chair.
What's that? Sorry?
All right, if we take extra time into the break, yes.
It's
Okay.
not my decision.
This supplementary from my head.
Is this a supplementary or a private question?
It's a mixed one.
If not per capita, given the raise in the cost of technology,
Cost of technology
how
is,
do you measure?
the cost of technology was totally accounted for by the adjustment. People are arguing about, should we increase the cost of the basket by a formula that automatically ties it to the growth of the population and the aging of the population. And I think that's an open argument. But I do not think, I think that the claims about the impact on equity, access, and health status of that gap are highly exaggerated, and we need to do more research on it, okay? If you ask people about their satisfaction with the four coupote, they go up, and they go up in all groups, and in the Arab population the most, okay? So I think, all I'm arguing is, I think that this is a misplaced, even if I agree that there's some privatization. It's far from undermining, and it's not the thing. It should not be a priority focus, okay? Now, I do agree with Donnie that the blur has to be better managed. And I think there's probably agreement within our group here at Van Leer, maybe in the room, that whether you have a completely public system or a completely private system or some kind of mix, the less that it's blurred and the more that it's fine-tuned, the better off you'll be. We're not fine-tuned when it's public, we're not fine-tuned when it's blurred, and we're not fine-tuned when it's private. And so our problem is with our fine-tuning and not with the relative proportion of public and private. So, I mean, I understand that I'm in a minority here, and I've been in a minority on this point since 2008, but I'm still here thanks to the generosity and intellectual honesty of the people who make the decisions. First of all, the question about the stakeholders was directed towards complementary insurance. And you said, I would assume that the private stakeholders, like the drug companies, would want to push it into the complementary insurance, because no, they want it in the basic insurance, because that's where the high volume is. And the committee that makes these decisions says, we heard you, now we'll decide. And only 70 of 600 drugs, each drug having an agent behind it pushing for it, get into the basket. And I can tell you, and Donnie might agree or not agree, I can tell you that there are many health services researchers in this country who would say, you know what, we could do with 35 and save the money. But of course, I'm in favor of more money to expand the basket, but there will never be enough. On the question of the gaps between groups, I just think we really don't know. I just think we need more data. And I'll just end on the question of the IMA and the incentives. I think, my feeling was, and Donnie can correct me, the last strike that we had in 2011, I thought that the Israel Medical Association was divided between senior physicians who are used to the old system, within which those who are the most senior and the most likely to benefit from private care dominate, and the junior physicians, and Amir, this is to your point, I think they come out of medical school saying, I want to earn a decent living, but I also want to give good care, and I'm not going to make my decisions based on financial incentives. But if you put me in a situation where you make it impossible for me because you pay me such a low salary, then if you put me in that position, then I think there are two groups. I know physicians who say, I will never do sharap, even though I'm allowed. And there are other physicians who do it, and when they do it, there are two types. There are those who are very pecuniary and mercenary about it, and there are those who say, look, you know, you could go private, you could go public, here's what I think. And I think these things need to be studied and they need to be fleshed out. But what I think is, if we start from the presumption that everyone is homo economicus, then I think we do a disservice. And that's why I think, again, just to summarize my position, if I had been on the Gurman Commission, I would have said, let's take the 3.5 billion shekels that we could get from the supplemental insurance, inject it into the public hospitals by allowing people to choose their physician, but don't pay the money to the physician per chooser, pay it to the hospital. And the hospital and the physician will negotiate over what does he get to be in the hospital for 18 hours and treat the people who chose him. And so that's, you know, that's my reactions to the various questions.
Well, I was going to raise it as a question, but I don't have time, so I'll just make it as like a general comment, my concern. I'm thinking a lot about deep-rooted processes, social-political processes. In such a divided country, such a divided society, which we saw the figures, the Gini index and everything, ethnically divided society. I wonder for how long can we manage at this pace? What I mean is that when will be the time, in my own view, that a large population of the middle class population, which is mainly Jewish and specifically, sometimes even specifically ethnic Jewish, when will they come and say, enough, we don't want to pay all these taxes for other people, we want to have our private, supplementary, whatever insurance, and just dismantle the system. Something like that is happening in Germany for other reasons, and that is my concern. But we ran out of time, so I will not be able to listen to the answers. Thank you very much for this discussion.